And I'll call back Professor Pape to give us the last talk on BK polyoma infection.
Thanks. I think, allow me one word to Dr. Reiner's talk. I think it's quite interesting because pathophysiology of what is happening may be quite similar in what you've seen in FSGS and in what you have seen in ABMR, and that's why similar components arise, but the history is a little bit different, what we do, and that is why therapy is quite different. And in some hours you'll hear that even in IgA nephropathy, many similar things that happen in pathophysiology and strategies are quite similar. So we've just spoken about the most important problem in long-term allograft survival, that is CABMR. But BK polyoma virus nephropathy is more or less the second most important reason for graft loss. And you've just seen the first subject was more or less about under immunosuppression, and now we have over immunosuppression, and it's still very difficult to get the right amount of immunosuppression. So BK polyoma virus is responsible for 10 or 20% of all graft losses. There are no vaccines, even not now, even with mRNA technology available. There are no antiviral drugs really working. The only real treatment we have is reducing immunosuppression, which is obviously of high risk of rejection. We can screen and monitor that, and the guidelines we had were from 2005, and that is why TTS said, okay, we shall do some new polyoma virus guidelines, and that were led by Camille Cotton from the USA and Hans Hirsch from Switzerland, and they started in 2020 with that guidelines, and formed 6 groups, and I had the honor to be the chair of the pediatric group in that guidelines, and more than 80 experts were invited to create new guidelines on BK polyoma virus. Literature was reviewed, evaluation according to grade happened, and draft was done, pre-final proposals, and the final manuscript was ready 2 years ago. And this is quite interesting. This is a photo of our final guideline meeting in 2022 in Basel, and that was more or less still in the Corona time, and that was for me the first meeting I attended after 2 years. And you see nobody with a mask on. And when I went by train from Germany to Switzerland, when we crossed the border, the train people said, okay, we're now in Switzerland, you can all cut off your masks. You know, Switzerland had a very liberal policy. And but after that meeting, 3 or 4 people, including the TTS president, suffered from severe COVID disease. So maybe this Swiss strategy was not too good, and some people just didn't dare to travel to Switzerland. And we all felt, and then we went in a restaurant for dinner, and it was very cramped, and we felt very bad in that COVID time in 2022 to sit in this restaurant. At least I was happy to stay healthy. So 9 months, 2 days, 4 rounds, 1 document. Was a very difficult guideline, as you can imagine. Always in these discussions where we don't have much evidence, as also in FSGS, there's very much evidence, evidence-based, and very much discussion going on what to do. And now I have at least some cases to discuss. So 6-year-old with kidney transplant, you do a routine surveillance biopsy at 6 months, T-cell mediated rejection, you don't find any BK polyoma virus, and but you had a positive load for BK, and then some weeks later it's risen to 14,000 copies. So what do we do? Do we treat that primarily as TCMR? Do we say maybe it's presumed BK polyoma virus nephropathy and we say the biopsy was too early, or do we repeat the biopsy? So what do you think we should do? Any idea? Okay, just think yourself. Another patient, routine checkup, BK polyoma plasma virus load is 10,000 copies per milliliter, stable creatinine. What do you want to do? A graft biopsy? Just reduces CNI because you have the BK polyoma virus load so low. Stop steroids, rechecking for weeks, give IVIG. Any strong ideas what to do? everything sounds somehow right, and that's why it's important to have these guidelines. So I can't present the complete guidelines in 15 minutes. This is just some about risk factors, and you can see that on the left side you see just presumptive nephropathy, which is seen as without proven of biopsy. And what you can see that obviously older recipient age is a risk factor, male gender is a risk factor, BK virus serous status, but most often we don't have that, so that doesn't help. It's relatively clearly that tacrolimus is a risk factor as compared to CSA, and there's also a lot of in vitro data that TAC does worse concerning BK virus. Use of T-cell depleting agents, acute rejections might trigger that. So there are some risk factors, but the problem is that more or less you can't really avoid these risk factors. Maybe you can't avoid T-cell depleting agents if you don't have to go there to give them, but you probably won't change just because of polyoma virus from tacrolimus to a CSA immunosuppression. Then a lot of this guideline is spent to how do pathology properly. So I will only highlight 2 points, and one is that if you have detected BK virus, you should do a kidney biopsy, not always, but only if it's clinically indicated. So if you have really a rise in serum creatinine, if you have proteinuria or hematuria or anything else. If not, you can just treat presumptive BK polyoma virus nephropathy. So only in those patients with stable renal function you might do or want to do a kidney biopsy if they have a very high immunological risk because they got T-cell depleting antibodies and whatever, or had several rejections before or something of that. So kidney biopsy is not standard in detecting PK polyoma virus nephropathy. And you see then there are several guidelines how to stain properly. That is something we do not need to discuss here. So, what is recommended? First thing, regular screening of kidney transplant patients for BK polyoma virus replication, and this obviously by PCR. So in the first year, the patients should be screened every first 9 months, every 3 months, and then every 3 months until 2 years post-transplant. And then we also try to include resource-limited settings in that. And we said if you don't have PCR available, then you can still do urine cytology for decoy cells. This is not as sensitive and not as specific as looking for BK polyoma virus DNA. That's why it's not anymore included in general guidelines. But if you don't have the possibility to do PCR regularly, then you can use urinary decoy cells, and if they are above 10 millions, then you probably should go to plasma BK polyoma virus load. And what you can also see is that urine BK polyoma virus load is not anymore just for some exceptional cases in the guideline because it's high in many patients, but the specificity is very low. So if you do PCR, do it in the blood. Okay. You shouldn't also do a biopsy if you have a resolution of BK polyoma DNA emia, unless you have any thoughts about rejection. And if you have reduced immunosuppression, obviously you should screen for BK polyoma virus a little bit longer to not miss a re-increase of that. But we still do not, finally in adults, know how about pre-transplant BK polyoma virus serology, how about specific T cells measuring, and some other points. So there's still a lot left for research. So next patient, BK plasma load. This is the second patient we had is 10,000 copies per milliliter, and 4 weeks later, and this was the right answer to the question before, just recheck one high amount of BK plasma virus is not enough, but you're asked to recheck after 4 weeks. What do you do now? Biopsy? No, because this patient has not an increase in serum creatinine, not in proteinuria. Reduction of CNA? Maybe. Stop of steroids? Probably no, because BK virus leads also to inflammation, and steroids are quite good for inflammation. Another recheck in 4 weeks? No. Administration of IVIG? Answer is no. I'll tell you later on. So this is a patient for reduction of CNI or maybe MMF. So treatment, just some highlights from the treatment. So the main recommendation is still to reduce maintenance immunosuppression, but we couldn't get one answer for everybody because there's no real evidence that reducing CNI is better than reducing MMF. And we finally decided that each transplant center should have its own algorithm how to reduce that. And the idea is either to start with CNIs or to start with MMF. And and you should reduce immunosuppression as long as you get below 10,000 copies. And you should also reduce immunosuppression if you even have a biopsy-proven nephropathy and if you don't know the DNA load. And here's what I told you. You can either reduce the antimetabolite first or the CNI because it's only weak evidence. And you should consider further steps to reduce immunosuppression if this doesn't work. So most often you just stop the antimetabolite. If you have started to reduce it, you probably don't stop your CNI, but if you have reduced your CNI, the next step would probably be to reduce your antimetabolite or you stop your metabolite. In adults, there's a little bit of evidence that IVIG might work, and that's why we suggest to consider IVIG as an adjuvant therapy, but there's no evidence for the use of cidofovir or of leflunomide. It's still quite often given, but we do not recommend both of these medications. And just to add that, there was also long-going discussion whether a switch to an mTOR inhibitor, that's something also we do in our center, might make sense, but again, unfortunately, there are no real good controlled studies to give enough evidence to that. So, what can you help to confirm that reduction of immunosuppression is needed in case of BK polyomavirus nephropathy? A graft biopsy? No, not really. High urinary load of BK polyomavirus? Also not really. Absence of BK polyomavirus specific T cells? Probably yes, because those patients who do not have any specific T cells against polyomavirus really need a reduction, and there's at least some pediatric data, not really good adult data on that. So one of the few moments where we are better in pediatrics than others in adult nephrology. Immunosuppression with tacrolimus, no, and combined acute rejection episode, absolutely no. And this is also something I don't have presented here because it's unclear, but what do you do if you have an acute rejection plus high levels of BK polyomavirus? It's also very difficult to get a real answer on that, but most often it makes sense to give steroid pulses because you have that high inflammation and also to reduce your maintenance immunosuppression. So give some steroid pulses, stop them, reduce your tacrolimus substantially, and that is often working, but it's very individual, so quite difficult. Now coming to the pediatric and PK/PD section in the guidelines, so you see this is quite similar to the adult recommendations with some changes. What you can see is here that we have that we say that you should monitor BK polyomavirus for 2 years, not only for 1 year in children. As you might know, children have a much higher risk for BK polyomavirus because more of them are naive, as for any other viral infections. And in the certain registry, we have seen that substantial amount of first detection of BK polyomavirus happens in the 2nd year after transplant, and this is why we should do a longer monitoring, at least if we can and if we have the resources for that. In pediatric patients, we said that we might do a kidney biopsy a little bit more fast than in the adults, because if you've transplanted maybe a large kidney from an adult parental donor into a child, it really takes time before serum creatinine increases. So if you have this combination of a large kidney in a small child, you might miss something like a rejection that is combined with BK polyomavirus nephropathy. So in these constellations, you might earlier decide to do a kidney biopsies. And we have said no adjunctive therapies in children, because there is some data on IVIG, and all these data does not really confirm that IVIG is of any help. So no leflunomide, no cidofovir, which is also nephrotoxic, no fluoroquinolones, yeah, nothing else actually as an adjunctive therapy. And it's still completely unclear what is about the D plus R minus mismatch, and this is mainly because we don't have the donor data. What is quite interesting, that there is some published data about monitoring of BK polyomavirus specific T cells in children, so that might really help to guide therapy. To be honest, it's data which is it's also be done by my own group, and that's why I have a positive bias to that. But we can now just start a study in Germany with funding by the German governments in all adult and some pediatric departments, where we try to start with steering of this reduction also by BK polyomavirus specific T cells in January or February next year, and hopefully we get an answer if this kind of immunologic monitoring may help. In addition, obviously, you have to make this kind of monitoring available if you want to use it, and actually that's not available everywhere. We also had to do something about cost and benefit, and I think that's quite important, because as you know, it's expensive to do these PCRs, but there are very good calculations in the manuscript that show that if you do that regularly and act, you have so many less graft losses that you spare so much dialysis time, more or less, for that it's really a good cost-benefit relation to do regular screening for BK polyomavirus in the patients, and that's why you should also not decrease that. Another question is retransplant. You should do retransplant. The risk is not that much higher to lose another graft after retransplantation because of BK polyomavirus, and you should not perform routine graft nephrectomy for retransplant. The idea was that maybe in the old graft there's so much BK polyomavirus that it might affect the other graft, but studies show that there's no real evidence for that. But again, it's a weak recommendation. Yeah. So this is just a fast summary of the most important points of the BK polyomavirus guidelines. What is quite interesting, I've presented these guidelines also at the IPNA meeting in Cape Town at the beginning of this year, and afterwards we had, which was quite nice, we had 45 minutes time for cases, and many people brought different cases of their patients with BK polyomavirus, and we tried using the guidelines to decide what to do with this special case. And yeah, again, you can see that guidelines are just guidelines, and it's not that easy with application for very complicated single cases, but at least I think they help for some general management of that. And anybody who is interested, this is open source, published in Transplantation, and yeah, you can just download the guidelines and get any further information I was not available to present here today. Thank you.